after releasing these adhesions, and now we will release this muscle. These are transferred on this muscle. We are releasing this. This will increase the space around 8 to 12 centimeter will increase. This we are doing the right side of this patient, releasing the rectus abdominis muscle, and the same procedure will be repeated on the left side. And the space can be created from superior up to the central tendon of the diaphragm, or below up to the retropubic space, and up to the space of and also include the space of bogras. We are doing this space in. This is the dissection where we are done laterally. And then again the transverse abdomen is released on the left side, sir. Usually the posterior separation is better than anterior separation because there are the less chances of injury, because usually the vessels and the nerves are passing through the transverse abdominis internal oblique muscles. Now the complete dissection has been done. Now we will closing the peritoneum. Posterior excess of the peritoneum should be, excess of the sac should be removed so that there will be less seroma formation. The excess of the sac has been removed. Now we are closing the peritoneum. After closing the peritoneum, mesh is placed and the mesh is secured with the anchoring suture. One or two anchoring sutures are used to hold the mesh. Now complete display of the mesh. Then anterior compartment is closed. After doing the excess of the skin and the subcutaneous tissues are being removed.
Dr. Zaj, please conclude the session.
One. Now, anterior sheath is closed. And the drain has, suction drain has been placed. The skin is closed. This is the final picture, placing the suction drain and the second staplers have been applied. is the final picture, sir. So final picture of the surgical team. This was the post-op picture after the 1 month. This was the post-op picture after 1 month. Conclusion: peritoneal flap hernia is an excellent and versatile method for reconstructing large ventral hernias arising in both midline and transverse incisions. The technique is safe and associated with a few complications and a very low recurrence rate. Thank you.
Thank you very much, Dr. Zahid. I think no time for question answers because we are running short.
Question please at the time of lunch. We are already late. Please, at the time of lunch.
There will be present on the table that we have done this patient on under epidural anesthesia. When we will get that patient.
Dr.
will
Zahid, discussion later on, please. Our next speaker is Dr. Mudassar and Shadar. He is consultant DHSK. How to sail smoothly in TAPP repair.
I would like to welcome our chairperson of the Jakasi, Professor Dr. Salim Iqbal Mir. A huge round of applause for him. And I would take this opportunity to congratulate and welcome Dr. Zafar Salim Khande, who has been recently inducted in the Central Council of ASI. And Dr. Sanji SK Basin, sir, also he has been inducted as a member in the ASI. So congratulate you both. Thank you.
Good morning, everyone. At the outset, I would like to thank the organizers and the Jakasi for giving me an opportunity to present in this session. So I'll be speaking over the next 7 minutes how to sail smoothly in a TAPP repair. So what is a TAPP repair? It is a laparoscopic hernia repair wherein the surgeon enters the peritoneal cavity. You incise the peritoneum, dissects the peritoneal space and places the mesh over the hernial defect, and the peritoneum is then sutured back. Before venturing into this, one has to make some preoperative assessment that patient has to empty his or her bladder before the operation. He has to restrict per and post-operative intravenous fluid administration. In case of technical difficulties, like after prosthetic surgery, scrotal hernia, or an extended operating time, we consider using a urinary catheter. Patients with unilateral groin hernia, they are asked to give his or her consent to allow a simultaneous repair in case we encounter any occult hernia during the surgery. So this is the OT layout where the surgeon usually stands on the opposite side of the hernia. And patient positioning is usually spine and the head down with the surgeon, with the patient slightly 15-degree tilted towards the surgeon. These are the port positions which we come across here. The camera port is usually a 10 mm port supraumbilical, and there are 2 5 mm ports. One, they are usually in the mid-clavicular line, but the contralateral port usually lies a bit below at the level of umbilicus. So once we come to the steps, we find that the first thing is to identify the peritoneal landmarks. So you enter the peritoneal cavity in a TAPP repair and you see a hernia over there. In the center you can see a small fold which is the median umbilical ligament, and 2 prominent lateral folds which are the medial umbilical ligaments, and just lateral to it you can find the direct hernia, and you can find the inferior epigastric over there, and this is the site for the indirect hernia. So then we went on to create a peritoneal flap. You start with an incision 2 cm anterior superior to the anterior sphenic spine. You can use any instrument like hook or scissor or a harmonic. One has to remember that we have to go 5 cm above the defect, and we have to move transversely. Once incision is made, the carbon dioxide makes up the space, it gushes in. You have to prevent sort of buttonholes into the peritoneum, and if there are any small oozers, they are to be controlled so that your plane of dissection remains the clean. One has to go between the 2 layers of the transverse fascia, because we know the transverse fascia is a bilaminar structure. And once you move medially, you have to stop at the medial umbilical ligament, L, medial umbilical ligament. And the first structure, important structure which you encounter here is the inferior epigastric artery. And one has to remember that you have to keep a fascia over it so that you don't injure it. So then we go into the lateral space, and one has to remember that in the lateral space we found usually the important nerves, and one doesn't have to make an attempt to identify these nerves because there's a fascia covering over the nerves which is called as Duluth fascia, and if you sort of strip these fascia, and you are going to expose the nerves to the mesh. So once the lateral dissection happens, then you start moving towards the medial dissection. Here you can see there's a small direct hernia going over there which is being reduced. And you start going to the medial space which is called as the space of radius. Here you have to dissect about 2 centimeters below the pubic arch or the Cooper's ligament. And you also go about 2 centimeters, you have to cross the midline as well. This is the dissection across the midline which has to happen. So once we are done with the spaces of radius and Bogros, then we move on to reduce the sag. This is technically one of the difficult parts of the TAPP repair, where the here this is the left side of hernia. Previous I was showing the right side of the hernia. I have deliberately chosen it because it was a bit difficult. So you come anteriorly first, the sag lies anteriorly, and then you go laterally, and then posteriorly, and then you come medially with the dissection. So you have to use the traction and counter traction maneuvers. The traction and counter traction maneuvers help here, and careful use of the cautery. One has to tease the cord structures away from the sac. This is where the sac comes into view, and you find a proper plane to separate it from the cord structures. This is the vas which comes also into view over here. One has to remember that the lower part of the dissection happens till the vas turns medially. That is the point where one has to stop. It is about 5 centimeters below the level of pubic arch again. So you get what is called as the triangle of doom, where the vas lies medially, the vessels lie laterally. And you also have to dissect the areas where you want to prevent the unfolding of the mesh, folding of the mesh from below. So this is followed by deployment of the mesh. Here the mesh has been folded about 2/3. It has to cross the midline. We pre-tie the sutures over the mesh. This is a polypropylene medium-sized mesh which is usually used. You can use the tackers. The first tacker has to be over the Cooper's ligament. There has to be a minimum of 1 fixation which lies over the Cooper ligament. But in my routine practice I do fix spiromedially as well as spirolaterally. Here one has to take care of an important aspect, that you don't have to tack below the level of the iliopubic tract, which would otherwise encounter the nerves. So in case the tackers are not available, you can go for the suturing. You can use the non-absorbable sutures like a proline, which you are using here. The suture comes over the pubic or the Cooper's ligament. One has to be proficient in suturing in case you want to avoid the expensive devices like tackers. So there is one suture over superolaterally also. Sorry, it's not coming. This is followed by the peritoneal closure. The peritoneal closure one can start laterally and go medially. You can use absorbable sutures, which could be barbed sutures, which could be PDS, or which could be Michael sutures. Make sure that there are no gaps in the peritoneum, which is very important. So in case at times the sac is there, which is large enough, where you feel that doing a sort of more of a dissection could harm the patient, so you take a decision of dividing the sac. You can divide the sac at the level of deep ring, and the distal part of it goes into the scrotum. That's quite safe and recommended. So, but there could be on-table surprises as well. Like here, we have a femoral hernia, which is above the pubic, above the level of Cooper's. Then you can have obturator hernias also, which you can see here. And a surprise like this, which can make any surgeon to sweat. This is something which is called as a Ben-David plexus. You can have this bunch of veins where there is difficulty in placing the mesh. So one has to have an in-depth knowledge of anatomy of the groin in order to ensure that you get a safe and successful laparoscopic hernia repair. Let me summarize. So peritoneum is a single-cell structure. Fat belongs to the abdominal wall. It has to stay with the abdominal wall. You follow the white and you will be right. This is the dictum which is followed. You leave a microfascia covering the inferior epigastric vessels. Midline is to be crossed by 2 centimeters. You leave a fascial layer to cover the nerves laterally, and start sac dissection anteriorly and laterally. Handle the vas carefully. You reduce the lipomas, if any, to prevent any pseudo recurrence. Never allow the mesh to roll inferiorly and laterally. The tackers or sutures are always above the iliopubic tract, and ensure that there are no gaps in the peritoneum, otherwise the bowel will go there and get entrapped. These are some papers which the hernia enthusiasts may be sort of interested in. You can see the critical view, essentially the same thing. Then concept of 3 zones and inverted Y. And there are golden rules for MIS hernia repair. Essentially all of them, they have standardized the hernia repair, and sort of this is with an idea to prevent the recurrences and prevent the sort of complications in hernia repair. Thank you very much. I invite you to HSICon Indore, which is happening next month. I'm being a state coordinator for it. So if anyone is interested in it, you can just register. Thank you.
Dr. Mudassar, wonderful presentations.
My question to you, Dr. Chadar, my question is, for those big hernias, you are just dissecting the sac. What is the incidence of seroma in these patients, and how are you managing them?
Yeah, the incidence of seroma is about, generally it is 0.5 to about 20%.
In large hernias?
No, it is general. This is generally, but in these hernias, the seroma chances increase. They go about 10 to 20%. But seroma should not be taken as a complication. It should rather be taken as sort of an happening in groin hernias, because once these seromas occur, they are to be managed conservatively for about, you can manage them for 6 weeks, even 3 months, 6 months. You don't have to touch them at all. So it is not a complication, not taken as a complication. Seroma is a happening which should be always.
About the incidence of this.
It is about 10-20%.
Thank you, Dr. Mudassar.
Thank you very much.
Our next speaker is Dr. Muhammad Sajid Bajaj, GMC Baramulla, RIRS for calcial divertical calculi.
Good morning, everyone. Today I will be talking about RIRS for calyceal diverticular calculus. As an introduction, what are calyceal diverticuli? Calyceal diverticuli are rare outpouching of upper collecting system. They are rare congenital developmental abnormalities in the renal parenchyma that result in non-secretory urothelial line cavities. They are filled by retrograde passive filling with the urine coming from the adjacent collecting system. How do we classify these calyceal diverticulae? There is an anatomical classification which divides it into type 1 and type 2. Type 1 are those communicating with the minor calyx or the infundibulum. The type 2 are those which are from the renal pelvis or the major calyx. The more common are the type 1, but the symptomatics are type 2, which arise from the renal pelvis. But there is one more classification called the functional classification for calyceal diverticulae, or the endoscopic classification, that divides the calyceal diverticulae from type 1 to type 4, depending on how open the mouth is and the status of the neck of the diverticulum. Different studies have shown that the most common location for calyceal diverticulae are the upper calyx, followed by the mid-pole and then the lower. Coming to the calyceal diverticulae, around 10 to 50% of calyceal diverticulae develop stones. They are often asymptomatic. When symptomatic, it could be loin pain, recurrent infections, renal abscess, and hematuria. What are the indications of management of CD calculi? All symptomatic CD calculi, calculi should be managed. What are the aim of treatment of these calculi? First and foremost is the stone removal, followed by improvement of the drainage of the diverticulum with obliteration of diverticular space. But the most important is we have to do all these things with minimal morbidity. So the treatment options are, we all know about the open techniques used previously, but they are obsolete now. The newer techniques we use in present day is the extracorporeal shock wave lithotripsy, percutaneous nephrolithotomy, retrograde intrarenal surgery, and rarely laparoscopic or robotic surgeries. So the management of CD calculi, if asymptomatic, we have to do observation, and if symptomatic, depending upon the size of the stone and which classification, this type of stone, type of CD calculi is, we either RIRS or PCNL is preferred. Oliver Trexler and renowned endourologists gave a recommendation for management of these CD calculi. He recommended that stones less than 12 mm, almost all, at all sites, RIRS is better as compared to PCNL, except in the lower posterior calyx, where RIRS and PCNL have equal success rate. For stones more than 12, again, at most places, RIRS is better, except lower posterior calyx, where PCNL goes ahead. But what is the reason why RIRS is preferred at these locations and why RIRS is gaining popularity? Over the last 1 or 2 decades, RIRS has overtaken PCNL as the primary surgery for renal stones in general. But what is the reason? One of the reasons is development of these scopes from rigid to semi-rigid and now flexible scopes. Flexible scopes, and now the new development is digital scopes with which are disposable, which are use and throw. And the development in lasers, from Nd:YAG laser to holmium laser, and now the new laser is thulium laser. Well, what the literature tells us about this, there was a study conducted which compared the retrograde intrarenal surgery with shockwave lithotripsy and percutaneous nephrolithotomy that showed that PCNL and RIRS are equally successful in, as far as the stone-free rate is compared. But PCNL has drawbacks like it's invasive, with blood loss is more, radiation exposure, hospital stays more. One more study which compared a percutaneous nephrolithotomy with retrograde intrarenal surgery, they concluded that RIRS should be considered standard therapy for stones less than 2 centimeters. A study in the American Journal of Urology from India, Hyderabad, from Chandramohan Vadi, he compared the same PCNL with RIRS. He concluded that both RIRS and PCNL are same in terms of stone-free rate and complications. But look at the fluoroscopic time. It's 31 seconds in RIRS compared to 337 seconds in PCNL. What are the steps of RIRS? We all know cystoscopy with stent removal, ureteroscopy and placement of guide wire, insertion of excess sheath under fluoroscope, flexible ureteroscopy, and lasing of the stone. So this is a cystoscopy done in a male patient. This is a prostate. This is a stent, pre-placed stent. We will place around 2 weeks before the procedure. We remove the stone, this stent. Under fluoroscopic guidance or the guide wire, we place excess sheath into the upper ureter. This is the excess sheath going up into the ureter under fluoroscopic guidance. Through this excess sheath, we are putting the flexible ureteroscope. This is the inside view of the flexible ureteroscope we put in the excess sheath. It's going up into the ureter, and then we are reaching the kidney. This is the pelvic calyceal system from inside. This is the upper pole calyx, upper calyceal system. Then we are moving to the mid calyx, and there we have found a stone. But after the stone is found, we have to look for the other calyces to look for the small stones, and then we lase the stone. So this is how it looks, the first picture. This is how it looks when we normally go inside the pelvic calyceal system. But when we go into the calyceal diverticulum, this is the picture we see. So what is the solution? So we have to open through this narrowing, and that is called the infundibulotomy. So infundibulotomy, this is done by the same laser. We do the stone lasing. We have to give multiple superficial cuts and gently try to push the scope with each cut. The laser setting should be low, and we should not core through the renal parenchyma. This is the most important step in this whole procedure, as any bleeding during this procedure, we have to abandon this procedure. In the video where you can see, we are just gently cutting through the infundibulum and trying to push the scope in. We are cutting the layer by fiber by fiber so that we will not core into the renal parenchyma. We have gone through the system, and there we can see the stone right in front of us, and we can lase it down. The next step is lasing the stone. The lasing of stone can be done either by fragmentation or dusting method. Fragmentation is we can fragment a stone into small fragments and then remove with the basket. In dusting, we will dust this stone into sand, and that will come out with the urine. But in CD calculi, because of the narrow diverticulum, we prefer doing dusting of the stone, and because basketing will be difficult in this case. So one should know when to stop, as in all procedures. So if there is a long neck with acute angle, we are not able to negotiate the scope. It's an obliterated neck and ostium. There is a false passage with bleeding that leads to poor vision, and if there is a diverticular perforation. What are the complications of RIRS in CD calculi? One is bleeding, both hematuria or perinephric hematoma. Urosepsis, rupture of diverticulum, false passage creation during infundibulotomy, urine extravasation, ureteral laceration, or damage to the scopes. In last 5 years, we have done around 14 cases of CD calculi. RIRS has been done. In 11 patients, we had a pre-op diagnosis, while in 3 patients, we got an intraoperative surprise. All these patients were successfully treated, except one in which we had to do PCR in that patient. DJ stent was put in all patients and was removed after 4 weeks. Most of the patients were discharged next day. Complications we encountered, in 2 patients we had post-op fever, which was managed by IV antibiotics. 1 patient has post-op gross hematuria, which subsided in 6 hours. 1 scope was damaged while doing one difficult case because of angulation. So just to conclude, this patient had a renal stone. We did an ultrasound. It showed a 12 mm calculi. It was confirmed on CT. When we went inside with the flexible scope, we could not find anything. We confirmed on the fluoro. It was seen that there was stone there was a red opaque shadow. What we could find is this, and it was correlating with the fluoroscopic findings. So we decided to open this membrane up. So we put in the laser. We slowly opened the membrane and tried to push our scope inside. And this was what was inside. Multiple small calculi filling whole of the calyces. It's like calyceal diverticulum with very small, thin membrane over it. Just to conclude, CD calculi are special category of calculi in complicated anatomy. Majority of CD calculi do not need active treatment. Of the treatment options available, RIRS is the most effective treatment modality with minimal morbidity, particularly in patients with lesser stone burden. Aim of treatment is zero residue of calculi with wide infiltrability. Stones should be dusted with laser and not fragmented. One should know when to stop. Thank you.
Thank you, Dr. Sajid. Any question?
Dr. Shah, it's a wonderful presentation. Just I want to know, you talked about the CD obliteration. How did you achieve it?
Conclude this session.
CD obliteration.
Basically, in the era of open surgery, there was a concept of that we have to close down this cavity. But with endoscopic advancements, now that part of treatment has been taken off. So only you have to give a better drainage and remove the stone burden.
Session needs to be concluded.
Sajid sir, a very wonderful presentation. I'd like to congratulate you on that. I have one comment and one question, rather. The comment is that because about the investigation part, sometimes as we saw, there was a non-contrast CT done. So if we have to be sure that stone is at an abnormal place, we may have to do a CT urography, which will exactly say whether this is, which will confirm whether this is a calyceal diverticulum or not. And we proceed as you rightly said. Sometimes we are not, despite best efforts, we will not be able to see wherever it is an opening from the inside. At that time, we can abandon the RIRS and we can directly do a stone-guided puncture and remove the stone, plus ablate the calyceal cavity as it is not communicating with the collecting system. Thank you, sir.
We conclude the session.
Thank you.
Thank you all for this wonderful session. I request Dr. Iqbal Salim sir to come on the stage and present memento to the moderators as well as presenters. Dr. SK Basin sir, please. Dr. Nasir Wani sir, please. Dr. Mir Mushtaq sir. Dr. Muhammad Zahid Rathar. Dr. Gulzar Ahmad Bhatt. Dr. Mudassir. Dr. Mudassir Shandar. Dr. Muhammad Sajad Bazal sir.
Yes, done a wonderful job. Can we have a round of applause?
Thank you. And we begin session third, paper presentation. For this, I will request Dr. SK Basin sir. Dr. SK Basin sir is Professor, Government Medical College, Jammu. Dr. Ghulam Muhammad Sheikh sir, Associate Professor, GMC Srinagar, ex-Associate Professor. Dr. Mukhtar Ahmad Thokar, Associate Professor, GMC Srinagar. Thank you all.
Good afternoon, everybody. Chairman Jakasi is here. Vice Chairman is here and Secretary Jakasi is here. I'll request the organizers to please, there should be some discipline. From every corner, there is so much voice. We are in the remote corner of Jammu and Kashmir, and we have all come here to have some healthy deliberations. This is third session. Only 2 speakers are there, and I am a bit disciplined man. 7 minutes means 7 minutes, and 2 minutes mean 2 minutes. First speaker is a very good friend of mine, Dr. Nazir Ahmed Wani, HOD, GMC Anantnag. He is deliberating upon laparoscopic management of ruptured hydatid liver presenting as acute abdomen.
Good morning, respected chairpersons, dear colleagues in the audience, my teachers, students. At the outset, I will thank the organizers, especially Dr. Gulzar, for inviting me. So I bring greetings from my place of work, GMC Anantnag. How to scroll it? So you all know that I don't want to diverge in the stories of hydatidosis. It is caused by echinococcus larval stage, and most important organ is infected is liver and followed by the lungs. Hydatid can infest any part of the body. So intraperitoneal rupture is very rare but a very serious complication. As you know, rupture occurs because of the increased intracystic pressure and peripheral location of the cyst in the liver, whether it be spontaneous or due to some trauma. So presentation usually is they present with acute abdomen, pain abdomen, they can have anaphylaxis, features of urticaria, they can even have certain death because of anaphylaxis, and appropriate timely intervention and medical management can treat the condition. So in our case, we had a 9-year-old girl which presented to our accident emergency with acute abdomen, severe pain with vomiting and without fever. So once we evaluated this patient, vitals were normal except tachycardia. And in inspection, patient had a distended abdomen, slight movements of the abdomen on the right side, no features of urticaria rash. Palpation showed a tender whole abdomen with guarding features of peritonitis. Percussion was a dull note. Auscultation was sluggish bowel movements. Investigations showed leukocytosis with eosinophilia marked 8%, and there was mild elevation of the bilirubin and enzymes. Ultrasonography detected intra-abdominal and pelvic fluid collection at a heterogeneous hypogaria measuring 10 into 8 into 8 centimeters involving the right lobe of the liver with multiple septations within the abdominal collection. CECT showed rupture of the anterior cyst wall with presence of multiple laminated membranes in the right lobe of the liver disseminated in the Morrison's pouch and right paracolic gutter with fluid into the up to the pelvis. So this patient was immediately resuscitated and was followed by the surgery. So being a young girl, we thought that we should go for laparoscopic surgery. These are the images. I don't think that video will work in this. Please, can you help me? There is a separate video. I request chairpersons to take care of technical hiccups. ये सेपरेट है ना वीडियो के लिए सेपरेट वीडियो चला दो सेपरेट में है लोडेड है इसमें वीडियो में पहले दीजिए आपको दूसरा वाला So once we went in, this was the picture. You see there is a balloon-like thing and it was localized by the momentum, and you see the laminated membranes were adherent to the parietal peritoneum. And once we started opening this area, there was a lot of hydatid fluid. So once we opened this and we started, first thing was we started aspiration of the fluid. We could see floating membranes lying in the Morrison's pouch. So this is first thing is that here conventionally we don't put betadine first, we will aspirate the whole contents. I'll try to make it easier. So once we make sure that we aspirate as much fluid as possible, we start separating the laminated membranes with blunt sucker tip from the peritoneal wall and put them at one place. So once they are put in, you can see here the liver cavity rupture and right lobe of the liver, and contents are poured in the Morrison's pouch. After doing this, we put 10% betadine. We almost sprinkle it over whole peritoneum and whole area and keep it for 10 minutes. Meanwhile, putting this for 10 minutes, we start retrieving the laminated membranes. We put a bag and start retrieving the laminated membranes. This was the easier part, but then coming to the, you can see the laminated membranes are entangled in whole omentum and gut. So separating them was a tedious job to do it. So we tried our best, but luckily it was peeling off nicely from the omentum and the gut tubes. So we tried to put everything, whatever we could retrieve in the bag. Then we again take care of the cavity. We locate the cavity and go inside the cavity. Again seeing the cavity, we again put betadine inside and keep it for 10 minutes there. Because the cavity was collapsed, betadine has not gone inside the cavity, so you have to put it again and wait for 10 minutes. Retrieve all residual laminated membranes from the cavity. There's a huge, then we go for partial pericystectomy. We remove as much wall as possible. Put everything in the bag, remove all, ensure that you remove all the membranes. Then again you inspect the cavity for any biliary leak. Again you give a thorough wash and clean the cavity. Luckily there was no leak and we could excise almost 60% of the cyst wall. So after that we put a drain inside and we came out. Again to presentation. So post-operatively the patient was put on second day only, started oral and albendazole therapy because this was not a conventional case, there was no albendazole therapy, this was an incidental diagnosis. So we put a tube drain which drained 300 ml, it was mostly the washes we had given, and subsequently we discharged the patient second post-op day, and seventh day post-operative the drain was removed when the drainage was nearly 20 ml. So patient is on follow-up for more than 2 months now. Now discussion a little bit because these complications of hydatid are very common: rupture, bacterial infection, anaphylaxis, compression of adjacent structures. As far as rupture is concerned, it is quite uncommon. Patient should be was put on albendazole therapy from first postoperative day. Sorry, I am going. So rupture is, it can be internal rupture and it can be external rupture. Internal, you know, cystobiliary fistulas, bronchobiliary fistulas, intraperitoneal, intrapericardial, intrapleural fistulas, and external, very rarely they can have a cystocutaneous fistula as well. Predisposing factor for rupture is young age, young patients, cyst diameter more than 10 centimeters, and superficial of the cyst. Then American College of Gastroenterology guidelines are that if you encounter such a case, go for open or laparoscopic surgery. Objective of surgery in such patients which present rupture and acute abdomen should be aspirate hydatid extraction of laminated membrane, irrigation with scolicidal agent, and subsequent washes with normal saline. Look for any biliary communication and then take it accordingly. We do not into great details. Then post-operative management is albendazole 10 to 15 milligram per kg body weight. In these cases, you have to give it for 6 months to 1 year, not conventional what you give for 3 months only. You have to go for monthly checkup for 1 year. For screening, you can go for ultrasonography, IgG for hydatid, indirect hemoglobin test, and CCT abdomen whenever you think that suspect some recurrence. After 1 year, yearly follow-ups, then follow-up should be terminated after 5 years. Recurrence rate is 0 to 28.6%. The conclusion is that complications of hydrosis must be included in differential diagnosis of patient with acute abdomen in an endemic area, especially when patient comes to casualty with rash and anaphylactic shock. Intraperitoneal rupture is rare but serious and life-threatening complication. Management and treatment depend on immediate surgery along with medical management. Patients should be kept for strict follow-up as there is chance of high recurrence in these patients. Thank you.
Ruptured hydatid cyst as such is a difficult proposition, but once it is a ruptured hydatid presenting as acute abdomen adds to that difficulty. It was a difficult proposition, well managed and excellently presented as usual. Only 1 or 2 questions from the audience and then next. Dr. Arshid.
Sir, congratulations for managing a very challenging case laparoscopically. I was wondering, basically this was a 9-year-old.
Yeah, 9 years, very small child.
Very small child. How much betadine actually you irrigated in the peritoneal cavity, considering the very low threshold of iodine toxicity as it is absorbed from peritoneal surface?
I don't think it was more than 20-30 ml. Small cavity, abdominal cavity, it was not more than that. and that should not cause toxicity in any case.
20 to 30 ml.
Lucky, ideally I would have preferred hypertonic saline, but
Yeah, absolutely.
betadine is available with me, so we could use
Absolutely.
whatever is
Because
available.
the problem with intraperitoneal ruptures is when we are in fact in diffuse abdominal hydatid doses.
But again, one thing I want to clear that once I completed this, this was a short video, edited video. I followed all the coils of the gut, and I also gave a normal saline wash after betadine.
Okay, that's wonderful, sir. Actually, whenever we are doing a diffuse abdominal hydatid doses, we are very circumspect of using large volumes of iodine, povidone, because it can lead to iodine toxicity.
And basic thing is that never put in iodine at the first instance in your cavity. You have to put normal saline, see any cystobiliary communications, and then you use betadine, iodine, whatever you are using. Any other question, please? Dr. Makhdoumi, sir, please.
Thank you, sir.
Two things come to my mind. It looked to me that most probably the cyst had already ruptured since long time, because it is quite adherent to the pleura.
No, there was not much, it was a flimsy addition.
And today it leaked, and luckily the patient she deceived you because there was no rash at start.
Yes,
You
yes,
didn't
that
doubt
was-
it.
that was-
Second thing is that once you put this much iodine, I was thinking, how did you, because this color, deep color, and but you saved yourself because it was saline came after.
That's what I told you, that the scenario is different from the conventional hydatid surgery.
How did you discern
I
that?
should have done that with normal saline, hypertonic saline. It is why I gave the
That's
hypertonic
the-
wash
that's
later
the-
on with normal
that's the
saline,
answer.
and then visualized the cavity.
Though I was
So the short
thinking-
video, it is about 1 hour surgery,
Yeah,
but
yeah. I was
just
thinking
5
of
minutes,
how
6
did we
minutes.
discern and was sure that there was no biliary leak from the cavity side itself.
Sir, basically whenever you have such a peripheral lesion where a leak is very, very rare, and we definitely meticulously follow the cavity, would put camera inside and see if there is a leak. So there was nothing like that. And we did it, we were sure that we did partial pericystectomy also. It was quite clear that there was no leak. That is one thing, sir. So this is not a conventional hydatid surgery, and sometimes you have to innovate things accordingly as per emergency.
Beautiful pediatric surgery done.
Thank you, sir. Thank you, sir.
Thank you very much. Thank you very much.
Now we invite one more speaker, Dr. Ejaz Ahmed Malik. He is a consultant at Shifa Hospital. His talk is surgical site infection and overview.
Good morning, respected chairpersons, my teachers, and my dear colleagues. I'll be talking about surgical site infections. It will be just an overview, although it's a very vast topic. But all of us, in our daily practice, see patients where we have surgical site infections and we have to deal with them. So we'll be talking briefly about these infections. Definition is, infection at surgical site which occurs within 30 days of surgery, or in case we know we have used an implant, then the duration has to be 1 year. So if we are using an implant, then the infection will be classified in surgical site infection even if it occurs within 1 year. What are the implications of surgical site infections? We know it increases the morbidity, increases mortality 2 to 11-fold. It increases the hospital stay, and definitely it all adds to the cost. And in US, it's almost $2,000 per admission. Types of surgical site infections, all of us must be aware of it. These are superficial, deep, and organ space surgical site infections. Superficial surgical and disease control centers. Infection occurs within 30 days of surgery and involves only skin and subcutaneous tissue. Then we classify it in superficial, and patient has to have at least one of the following criteria, like there should be purulent discharge. We should be able to isolate an organism either on culture of tissue or fluid. Incision deliberately opened by surgeon, or a surgeon diagnoses it as superficial surgical site infection. We call it as superficial surgical site infection. Deep, when we have involvement of muscle and fascia, and patient has at least one of the following: purulent discharge, again organism isolated from the culture, and patient has fever of more than 38. We have an abscess or other evidence of infection, or a surgeon diagnoses it as deep, then he classify it as deep SSI. Then third is the organ or space surgical site infection. Infection occurs within 30 days of surgery or within 1 year if there is an implant, and involves any part of the body excluding skin, fascia or muscle, and patient has at least one of the following: there is purulent discharge from the drain placed in the cavity. We isolate an organism, or there is an abscess which has been diagnosed by a surgeon, or we have an abscess on radiological evidence. We can further classify it based on severity. It can be minor when we have just discharge, or it can be major when we have discharge with tissue breakdown, or we have systemic illnesses associated. It can be classified as early, intermediate and late depending upon the duration. Within 30 days we call it as early. Within 1 to 3 months we call it as intermediate, or late after 3 months. Then what are the risk factors? This is what is important, and this is what I would like to stress upon, so that we can identify the patient class where we have high risk of surgical site infection, and we can take all those precautions so that we can prevent the infection. The patient factors: older age, immunosuppression, obesity, diabetes, chronic inflammatory process, malnutrition, peripheral vascular disease, smoking, anemia, radiation and steroid use. Out of these, older age, diabetes, malnutrition and steroid use are very significant. Local factors include poor skin preparation, contamination of instruments, inadequate antibiotic prophylaxis, prolonged procedure, local tissue necrosis, hypoxia and hypothermia. And about microbial factors, we need to know about the wound class, and if there is prolonged hospitalization or resistance to antibiotics. About wound classification, I think wound class we all know. We have class 1, 2, 3 and 4. Clean wounds, clean, contaminated, contaminates and dirty wounds. And depending upon the wound, the risk increases. A risk of post-operative infection in class 1 clean category is just 2%. And as the class goes up, in dirty class 4, it's more than 30%. So once we know all these things, we can explain the patient, beforehand that there's a higher chance of getting a surgical site infection. About pathogens, we mostly see in the isolates in the cultures. Staphylococcus aureus negative has highest, in one of the studies, the percentage was highest, followed by Enterococcus and Staph aureus. Then again, a study done in 2013, the isolates were Staph aureus among the gram-positive cocci, and among gram-negative bacilli, Pseudomonas was the commonest. Another study was done in 2013. It was published in Annals of Clinical Microbiology. The commonest pathogen isolated was Staph aureus, followed by gram-negative bacilli and E. coli. Again, a study where they found gynae procedures, overall surgical site infection rate, gynae procedures, it was found to be 11%, emergencies, LSCS 3.9, and elective, it was lesser. How to prevent surgical site infections? We have to focus on pre-op, intra-op and post-op factors. In pre-op factors, we have to reduce the skin microflora by antiseptic showering. Pre-operative bathing or showering with antiseptic soap versus plain soap. There have been multiple RCTs conducted where it was concluded that there is no difference between an antiseptic soap versus a plain soap. Pre-operative hair removal, multiple studies, again RCTs have been done, and it has been concluded that hair removal with clippers and cream may make little difference, and if at all we have to remove the skin, it has to be removed by clippers, otherwise it's not required. Skin preparation should be always done by alcohol-based antiseptic solution based on chlorhexidine. Antibiotic prophylaxis should be administered within 60 or maximum 120 minutes. It has to be...
Please
this-
conclude, please.
Sorry,
Come to the conclusion slide.
Okay. So there are a couple of strong guidelines from WHO. Hair removal, again, as I said, only if at all is required, should be done by clippers. Bowel preparation, it should be, in GI cases, should be used both mechanical as well as drugs. Staph carriers, they should be given miprocin 2 weeks prior to surgery. Antibiotic, as I said, 60 to 120 minutes before surgery. Surgical hand preparation, antimicrobial soap, or we can use alcohol-based hand rub. So management part, most SSIs respond to removal of sutures with drainage of pus if present, and occasionally there is a need of debridement and open wound care. Incomplete sealing of wound edges can be managed by secondary healing. Just a word about Halsted's principle of surgical techniques. We should handle the tissues gently, preserve blood supply, strict aseptic technique should be used. Closure should be with minimal tension, accurate tissue apposition and obliteration of dead space should be done, and we should maintain hemostasis. So this is the conclusion. Global Alliance of Infection and Surgery bundles for the prevention of surgical site infection worldwide. We have to do pre-operative bathing or showering, surgical antibiotic prophylaxis, hair removal, surgical hand scrub preparation, second antiseptic preparations. Thank you.
Thank you very much, Dr.
Thank you.
Azaz. Surgical site infection as such is a very challenging task nowadays. I put it three ways. Surgeon's responsibility, environmental responsibility, and patient responsibility. And unfortunately, surgeons are leading in contributing to SSI or PSSI. The presentation which he made was approximately of 15 minutes, and that in view of shortage of time, we could not, but it was a wonderful presentation. We are short of time, no question. Thank you very much.
Thank you.
Thank you all for this wonderful session again. I request Professor Ajaz Ahmad Rathar sir, Head of the Department, Skims Medical College, to present mementos to the presenters and moderators. Dr. SK Basin sir, please. Dr. SK Basin sir, please. Dr. Mukhtar Thokar, please. Dr. Ajaz Ahmad Malik sir. Dr. Nazir Ahmad Wani sir. Yes, sir. Dr. Ajaz Ahmad Malik sir, Shifa Hospital, Srinagar.